Well, good afternoon, everybody. We will start with apologies. I'm sorry, both our main broadband line and the backup line went down, typical. So sorry about that, 15 minutes late. We'll try and make up some time. So good afternoon to everybody. Welcome to the first Yorkshire Care Equipment webinar. Our subject today is Understanding Long COVID. So my name's George Hulbert from Yorkshire Care Equipment. It is good afternoon for most on the call, but still morning for some. We've got an international audience today, some from Australia, United States, Malta and Ireland, just to name a few. So I'm joined today by Rachel Wilson. She's an independent occupational therapist, medico-legal rehabilitation cost consultant, and also Porrick Finn, our own in-house Band 6 physiotherapist. The topic of our webinar today is, as I've said, understanding long COVID, but also managing client symptoms and supporting their recovery. So Rachel will cover the occupational therapist perspective on the current advice which is out there and the theory behind what's been done. Porrick will cover specifying equipment based on clients' long COVID symptoms and needs in order to help management and rehabilitation. So there will be a question and answer session at the end of this seminar. So please use the chat facility, either posting privately or publicly throughout the session, and then we'll look to answer the questions as they come up. So for us at Yorkshire Care Equipment, long COVID's a relatively new topic. We're very much learning, researching, speaking to others about this, and we do hope that the session will be useful for you today. So we'll just pull up a few slides we've got here. So we'll start with, first of all, by covering some stats. This first slide is really looking at the positive. As it shows on here, those that have had the first dose, just under 25, which I understand is now just over 25 million, which is a fantastic achievement in this country. And also on the real positive, solemn of course, but positive that the deaths are decreasing with an impact of the vaccination. However, very prevalent is long COVID, so those who are suffering with long COVID. There's an interesting stat here that we picked up that at least 10% of those infected with COVID-19 were experiencing at least one symptom for 12 weeks or longer. And looking at the amount of, according to the Johns Hopkins data, the UK has over 4 million cases of COVID. So if we take 10% of that, we're talking nearly 500,000 people who are suffering with symptoms of long COVID. So it's something very prevalent in people's lives and really key today. Another stat on this same slide is that between 50 and 89% of those admitted to a hospital with COVID have at least one symptom carrying on after 2 months. So again, something which is showing it's very, very key. We've been getting a few comments through from patients that we deal with. One of them here, she mentioned she was struggling with her energy and fatigue levels. She's got an occupational health nurse and a CBT nurse, but in so much joint pain and terrible brain problems, she's forgetting how to turn on a tap, button up my coat, and she's been 10 months with long COVID. So really, as this slide suggests, that's why we're talking about it. It's something that's very prevalent amongst us today. Other quotes you'll have seen in the media. This particular one we pulled out, so I'm 38. I wonder if I'll ever be able to walk again without crutches. Will this continue to get worse? Will I end up in a wheelchair? So key for us is to be able to signpost our clients, impart our knowledge that we gain to our patients. So anything that we understand, we share for the greater good. We'll see from these stats here how it's affecting people in their day-to-day life. Some very interesting figures. So 71% in a survey said that it was affecting their family life. And then we've got over a third where it was impacting their ability to care for their dependents. Most of the respondents in the survey said that long COVID affected their ability to work, and then a third affecting their finance. So we can see from these 4 areas that it's affecting people in just about every part of their life: family, care, work, and finance. So that's really why long COVID is an issue. It's something that we need to seek to address. Rachel will help us on that as we go through the slides. But like yourselves that are on the call, our mission is to enhance quality of life, and that's really key for us. So before I hand over to Rachel, just a little bit about ourselves. Company Yorkshire Care Equipment. So we're a family-run business. You see a few of us there. Established in 1972. We've been working amongst healthcare professionals for a long time now. Very interestingly, really, in the last year, we got involved setting up a few of the Nightingales, and it was great, really, to be working alongside the professionals helping fight the coronavirus. It's been a very interesting and formative time for us. Our normal business is really doing assessments for individuals, so a specific piece of equipment for them, and also supplying equipment direct into care establishments such as hospitals. We very much believe in a holistic approach at Yorkshire Care, so we understand what equipment can help manage symptoms and also aid recovery, so aid rehabilitation. So on that, I'll thank you again for joining. Apologies for being late. We'll hand over to Rachel now. I'll stop sharing my screen, Rachel, if you want to show yours.
Bear with me now then.
Sure.
Right, can you all see that?
Not yet, Rachel, for me.
Can you see that now?
Yeah, there's some messages coming through confirming that. That's great. Thanks.
Okay, so just to confirm, everyone, I will have all of my slides sent out afterwards, and I know this is being recorded, so in terms of note-taking, everything, you're covered with the slides coming out.
Sorry, Rachel, I think we can just see your internet there. Have you shared the right screen?
I've got my presentation in front of me.
Okay, how many screens have you got there?
When you say how many screens, I've just got one screen.
Just one screen, yeah. We can just see the Chrome tab. So if you just cancel sharing and share your whole. Wait a minute. Let's just have a look. Sorry, would you mind? I think someone else might have been sharing then. Do you want to share again? There we go. We can see it now. Thank you very much. Sorry about that.
Great. Sorry, everyone. Tim Holt, you're in my screen. Put your thumbs up if you can see it. Great. Lovely. Thank you very much. Right. Hello, everyone. I'm so sorry for the delay in starting. And I'm hoping all the technical issues will be fine. And I will share the slides afterwards. Okay, so I'm Rachel Wilson. I'm an independent occupational therapist. I describe myself as a generalist. I've got a background of working through the NHS rotations in acute, rehab and community-based services. I worked my way up to band 6 before moving across to working as a case manager for long-term conditions in the community. And then I moved across to the local authority before taking a step back to work as an independent OT. and my role now includes case management, occupational therapy and expert witness work with a range of clients, from an elderly lady who's wanting a stair lift or some support with rehab after a long hospital stay, or after an illness at home where she's not been in hospital, through to working with catastrophic injuries, so people with multiple amputations after a catastrophic injury, for example. So I haven't actually worked with anyone with long COVID yet, so you may well wonder why I'm providing this presentation to you. But none of us yet are fully specialist in long COVID because it's still so new and the research evidence is young and limited. But there are lots of you who are working at the forefront of emerging services in this area. And those of you who I have spoken to are incredibly busy and didn't really have time to step aside to do a presentation like this. So I am not a specialist, and that's my biggest disclaimer through this. But what I wanted to be about was to bring in the information that's out there on a national basis from the NHS and from a NICE standpoint, and looking at what our professional and governing bodies are asking of us. And I've spoken to some local staff in these developing services about their experiences to date with long COVID. So really it's about encouraging and signposting today more than teaching. So long COVID presents many challenges when we're trying to determine best practice standards based on current evidence. There's no absolute clinical definition or clear treatment pathway, and there is minimal, although definitely evolving, evidence base. So you can see here NICE has provided some definitions of acute, ongoing symptomatic and post-COVID-19 syndrome. And the National Institute for Health and Care Excellence, along with the Scottish Intercollegiate Guidelines Network and the Royal College of General Practitioners, have defined post-COVID syndrome as signs and symptoms that develop during or following an infection consistent with COVID-19, which continue for more than 12 weeks and are not explained by an alternative diagnosis. The condition usually presents with clusters of symptoms, often overlapping, which may change over time and can affect any system within the body. Many people with post-COVID syndrome can also experience generalized pain, fatigue, persisting high temperature and psychiatric problems. Post-COVID-19 syndrome may be considered before 12 weeks, while the possibility of an alternative underlying disease is also being addressed. So you can see here, there are a considerable number of symptoms. This is not exhaustive. A systematic review has highlighted 55 different long-term effects, but common symptoms of long COVID include breathlessness, headaches, cough, fatigue, and cognitive impairment or brain fog. And there's also emerging evidence that some people experience organ damage. The team in Leeds, when they were developing the COVID-19 rehab pathway, they identified the most common symptoms in their initial triages, as shown here. And they noted that if you combine all the psychological symptoms related to anxiety, cognition, PTSD, they then become the third most common factor after the severe fatigue and the breathlessness. In October, the Leeds Community Healthcare Trust identified the following common themes in their caseloads at the time. So as for 153 with long COVID on their caseload, the average age was 48 years with a range between 18 and 72. Women were affected more than men, with a high level of fitness and no pre-existing respiratory problems. The main symptoms, as we've already said, were fatigue, breathlessness, and cognitive problems and anxiety, this brain fog. Many had never presented to hospital, but were really suffering with these long-haul symptoms: autonomic dysfunction, bursts of tachycardia happening both at rest and on exertion, and post-viral fatigue, which seems to be the most common reason that people are not being able to return to work due to this brain fog and fatigue-related cognitive impairment. There was oxygen desaturation on exertion, and chronic COVID sufferers were really finding that with weakened immune systems from being isolated, a lot of us on lockdown, even without long COVID, we're going to be so susceptible to bugs, but people with chronic COVID are developing these recurrent chest infections as they're trying to reintegrate with other people and getting out and about again. So in October last year, we had this 5-part package of measures offered from the to boost the NHS support. They're for patients who have had COVID, but past hospital admission is not a requirement. We've got the COVID recovery website, which was launched in July, which is to be used by patients and families and carers relating to physical, emotional and psychological well-being. There's an online tailored rehab program that enables patients to be monitored by their rehab teams. You can't access that without a special referral, and it's to help people stay on track with their care. There's £10 million invested by the government to set up these specialist COVID assessment services across England, which I'll be talking about. There's some funded research on long COVID to better understand the condition and refine treatment. And there's a long COVID task force involving patients with long COVID, medical specialists and researchers. And our professional bodies are really pleased. They've been supporting the way this is tailored for this rehabilitation platform, but there are just some concerns. We don't want people to fall through the gaps, because as much as remote and virtual rehab is fantastic and really good to use the technology for that, it's not suitable for everyone. And then last month in February, the Department of Health and Social Care have pledged £18.5 million to tackle long COVID through 4 research projects to help better understand the causes, the physical and mental health symptoms, and the treatment for the 1 in 10 people with symptoms after 12 weeks. And we've got the COVID-19 rapid guideline from NICE, and that was published in December last year after an initial scoping exercise. And it's useful, it guides us through things, but it's not groundbreaking compared to assessing other conditions really. So it takes us through identifying people with these needs, people with ongoing symptoms of COVID-19 or post-COVID-19 syndrome. It talks through assessing people with new or ongoing symptoms, investigations and referral, planning care, management in different ways, follow-up and monitoring, sharing information to ensure continuity of care, and it talks through service organisation in this new direction. And there are some concerns being raised by our various professional bodies that this guideline still doesn't quite do enough to connect people with long COVID to the right services to meet their needs. They feel there's some gaps around common treatments like pulmonary rehab, reconditioning, fatigue, and a lack of detail on patient pathway development, multidisciplinary team working and self-management. And I think most professionals are in agreement that the guideline needs to be expanded further, but by the people who are at the forefront of doing that rehab, so that the pathways are clearly described and as effective as possible. And NICE has come back and said, of course, it's going to be adapted as new evidence emerges. So we've already talked about the government investing 10 million in these long COVID clinics and teams and assessment services across the country. And I've spoken to the OT in our local team here in Harrogate, and the therapy team consists of a half-time OT, a half-time physio, and access to a respiratory nurse and a medical consultant. And I'm so sorry if you're watching, I can't remember if it was a rehab medicine consultant or a respiratory consultant, but I know both are heavily involved across the country. And in Harrogate, we are using a 3-standard approach to referrals. There's a trigger at 6 weeks after an ICU admission, 12 weeks after a standard ward admission, where they complete screening and referral as required. And anyone who hasn't presented at hospital but is experiencing these long haul symptoms, the staff are really encouraging local GPs to do the screens and refer on as required to try and stop people falling through the gaps. What we need to remember is it's going to be different. Even though the guidance is fairly standard, it's going to be different in each region depending how teams have been set up. And it's really essential that we remember that the staff in the teams, they're often working part-time alongside other jobs with limited but emerging evidence that they're trying to stay on top of. They've got stretched capacity and quite long waiting lists are already developing. Their intervention is very much focused on education for clients and other professionals, and they're developing their own and their patients' understanding of the symptoms and how they can subsequently manage the expectations of everyone. There's a real strong focus around teaching people about learning to manage and live with their symptoms. And that runs true, to be fair, alongside all the other long-term conditions we're used to working with. So the role of these staff in these clinics will overlap with existing colleagues in community-based services, and collaboration and communication between settings really must be encouraged to provide effective and efficient service to individuals. So the clinics and teams may be led by secondary, primary or community care clinicians, including integrated care and advanced clinical practitioners, and from a range of specialties with referral to other specialist teams as required. We've got physios looking at respiratory function, strength and exercise tolerance, amongst other things. Specialist nursing roles, we've got the district nurses, community nurses, psychiatric nursing, clinical nurse specialists and general practice nurses, all providing their holistic assessment and treatment of patients and the wider family needs, and supporting coordination of services more widely where appropriate. We've got OTs with their dual training, providing a personalised and occupation-focused approach to assessment, looking at cognition, delirium, mental health, functional outcomes, independence in occupations, including support for self-management and social prescribing. Psychologists are looking at cognition, mental health, providing support for patients managing their persistent symptoms, and providing access into services such as IACT and the other wider health, social care and third sector provision, and looking at pain, fatigue and neuro rehab service referrals. We've got the dietitians advising on the impact of nutritional status, which may take the form of malnutrition or for those overweight or obese. As part of our workforce planning in this area, we really need to consider professional responsibility and accountability. We need to embrace working together as MDT members, communicating between health and social care staff from all sectors, and we need to do this without fear, judgment or presumption. And we must avoid the blame culture that we can fall into at times of stress, the us versus them, the health versus social care, the statutory versus private. We need to embrace these competency-based learning and working scenarios that we've been working on over the past few years, accepting the ongoing need for blurring of our boundaries, honouring our underpinning professional philosophies in all that we do. And this will help us not to dilute, but to strengthen our worth within our teams and our services. We need to manage expectations and remember that workloads have doubled in some cases. We've got our pre-COVID rehab and we've got our long COVID rehab needs. We're running response services as well as rehab services alongside each other. So it's really essential that we all take responsibility for monitoring team dynamics, capacity, workforce resilience, and using reflective practice to give our best to our clients, ourselves, and each other. So we must work collaboratively, now more than ever, and all of our governing bodies have provided guidance to us as clinicians about how best to work with our patients and clients, as well as how to look after ourselves. But all of the guidance that I've seen to date has reminded me that we have our existing codes of conduct and ethics, our standards of practice, and in order to work in the roles that we do, these remain our predominant obligation, with COVID guidance being just that, it is guidance. So if our professional experience and clinical reasoning indicates the need to steer away from the guidance at times in order to meet a need, reduce a risk, optimise better outcomes, then working as a team and relying on our professional expertise, documenting our decision-making processes, should all enable this to happen effectively as required. So moving on to our process of assessment and treatment, whatever professional background we come from. The research I've done has kept bringing up the two main screening tools. There may be others across the country, and I'm sorry, and across the world. I'm sorry if there's things here that I haven't included. But the two that I've noted, the COVID-19 Yorkshire Rehab Screening Tool is a comprehensive multi-system telephone tool which has been developed by an MDT rehab team from Leeds, Airedale and Hull NHS Trusts. And it's used to assess and capture symptoms and to guide rehabilitation interventions. And it's readily available. You can download it free of charge online. It's easy to get get to and have a look through, and useful when you're screening your clients and also talking to GPs and what have you. The post-COVID-19 functional status tool is an ordinal 6-point tool used to measure a variety of functional outcomes during recovery from COVID. The scale, which has steps ranging from no symptoms all the way through to death, can be used to measure the impact of symptoms on functional performance, as well as the effects of interventions on the recovery trajectory. It can be completed by clinical professionals or by the patient themselves using a flowchart. And if the patient is not able to complete it themselves through cognitive reasons or any other reason, it is suitable to be completed by a family member or a carer on their behalf. And they're recommended to do the assessments at the first assessment, either in the clinic appointment or by the GP, 4 to 8 weeks after the first appointment, and another 6 months after the first appointment. And outside of these screening tools, our assessments need to be gathering information from the individual, their family and carers. Really important to establish the pre-morbid baseline and take any reports of their own perceived changes to functional independence in activities of daily living. We need to be identifying difficulties with cognition, physical abilities, attention, memory, executive functioning and orientation, posture and positioning, tolerance, muscle strength, upper limb function. We need to screen for visual difficulties and sensory changes, anxiety and depression. Are there any issues with capacity and insight? And are any safeguarding reviews or alerts required? And we need to remember that early intervention is essential if we want to reduce the risk of acute and unplanned hospital admissions. So when it comes to goal setting, we need to be working with patients and clients to set ongoing goals and review. We need to use active listening, and we need to support the person to have complex and difficult conversations about what actually matters to them. I know the Royal College of OTs are really talking at the moment about this big rehab conversation, and if it doesn't matter to the client, it's not going to work, it's not going to mean anything. We need to focus on building confidence through positive experiences and supporting the person to establish a healthy balance between self-care, productivity and leisure. We should all be using a graded approach to build resilience and skills to return to roles, routines and occupations without fear of failure or risk of doing too much too soon. And this is a real fine balancing act. The goals need to be well coordinated and global between all the therapists and the treating teams to ensure that the patient is working towards what matters to them. And we need to remember what might be affecting the person's ability to identify and set those goals and subsequently to engage in the rehab, financial concerns, mood and motivation. And these issues may trigger a referral to other team members or other services for assessment, investigation and support. So this bit puts me onto, if I just use myself as an example, the stats at early triage stage that the Leeds team found, mean age 48, affects women more than men. That's almost me, give or take a couple of years. So I work full time, but I have my own business. So if I don't earn, I'm scuppered. I have a 10-year-old. I have a self-employed husband who is in close contact, non-essential services, who can't work or earn during lockdown. I live out in the country. My family aren't in a position to help. So what if I get COVID and develop long COVID? What's important to me? I don't necessarily need to get washed and dressed if I'm working from home. I haven't got an employer to worry about, but I'd have massive financial concerns. And how would I get my daughter to and from school? So what would be the difference between my goals and your goals? Your parents' goals, your grandparents, your children's goals? What different goals might they all have? And how can we facilitate setting those in realistic ways that matter to each person to encompass that self-management without crisis and without these bottomless resources to support them every step of the way? So coming on to engaging and providing the rehab and moving forward in that journey, when we're structuring therapy provision and identifying appropriate staff and skills mix, we need to consider whether the needs of patients and service users are likely to require a specialist approach. So that will be where the individuals with the most complex needs with the requirement for individualized input, targeted approaches, supporting people whose needs are less complex and who are at lower risk, but they still require this bespoke input, or a universal approach, facilitating self-management for those with straightforward needs, but they might complement targeted approaches as well. So talking through some of these specialist and targeted approaches, we might be looking at environmental interventions, teaching strategies and advising on assistive technology and adapting the home, cognitive rehab, looking at all the areas of cognition, executive functioning, memory, orientation, and teaching strategies to use memory aids and communication approaches. Provision and grading of occupation-focused upper limb exercise programs, moving and handling interventions, mobility interventions, and finding walking aids, referring into wheelchair services, identifying hoisting needs, vocational rehab, which I'll touch on separately, education and intervention around psychological well-being and addressing the barriers to people staying connected with their families and friends and work, encouraging engagement in meaningful occupations, physical activity and relaxation to promote wellness and well-being, and referral onwards to more specialist services where they're required, such as cardiac, pulmonary and psychological services. And then the targeted stroke universal services might be leadership and supervision of reablement services, breathlessness and fatigue management, self-management techniques, sleep hygiene, facilitation of group or individual rehab delivered by other competent professionals. And this one came about a bit more yesterday in my sort of radar. We talk about upskilling and training of therapy assistants, support workers and leisure providers. My son's a local personal trainer, and he was telling me yesterday that a lot of his colleagues are now taking certifications in training for people with long COVID. So they are non-medical, non-clinical people in the leisure industry working to develop improved fitness and programs for people with long COVID. And I think that's really, really good to see that spreading out. Providing remote services where interventions can be provided effectively via phone or video, referrals to social prescribing schemes, self-management resources that are accessible to a range of audiences, and advice and support to families and carers. So you can see there's this going from specialist all the way through to universal. There's a real spread of ways that we can help. I'm not going to go through in detail about rehabilitation models. I always like to use this one when I'm talking to an audience of not just OTs, because it covers everything and it can be incorporated by different professionals, looking at the person, their environment, and the occupation, task, activity that they want to engage in. It helps us to retain a focus on what's important for the patient without using lots of jargon. Changing needs over time and in different environments, we can look at long-term goal setting. We can look at the impact of the person's identity, relationships, roles, responsibilities in the immediate and longer term. And we can identify existing skills and strengths that the client has that they can then use to overcome the barriers to performance and participation in their daily activities. We can look at the range of impairments and disabilities experienced and the rate of recovery. We need to look at the personal environmental circumstances, including comorbidities, pre-morbid functional levels, psychological background, what do they use normally as their coping mechanisms, their self-efficacy and ability to adapt, the home environment or place that the person's going to be working, how can they adapt to the environment or how can the environment be modified. The social environment is really important here. Looking at the social group the person is a part of, their economic circumstances and any barriers such as PPE and ongoing social isolation. Helping people communicate while they're in isolation, I've touched on that already. Holding those difficult conversations about future outcomes will be fundamental to successfully working with these people and keeping them motivated. What's their job or their vocation? Is it paid, informal or voluntary? It doesn't matter. Other activities that the person finds fulfilling. And I go back to when I talked about me, what's important to me, what do I absolutely need and want to do? Obviously, for individuals who have received intensive acute treatment in hospital, some of those early stages will be personal care, getting washed and dressed, being able to make a snack when they're discharged from hospital. But actually, throughout their recovery journey, looking at the occupational balance through personal care and other important issues in their life are going to be essential to get their motivation on board. And I've just put this slide up to remind us of the various specialist services that we've already got that are useful to us in referring, but also there's different ways of using them when we're facing stages that we are now. Do we refer in? Can we seek support from each other and give our clients the best we can by developing knowledge and competencies to provide services in the most clinical, time and cost-effective way? Can we arrange in-service training and information sharing, using existing handouts that are useful for patients but can be helpful to us as staff as well when working with patients with different conditions, so that we gain an understanding of symptoms and self-management advice? My experience as working as an OT in a non-traditional role with long-term conditions, it really opened up my eyes to the wealth of accessible information that's out there, and it's relevant to all of our roles in understanding the journeys of our clients and on how we can work together to support them without duplicating or stepping on toes. Now, I haven't added to this slide, but I do want to make a point of remembering, because I know our audience is varied, but we've got our social care colleagues here, benefit support services, housing services, voluntary services. We need to tap into all the resources, the specialist resources that are out there. So in terms of the focus of rehab, it follows similar principles to chronic fatigue management, really. Now, again, another disclaimer, I'm not a specialist in chronic fatigue syndrome or ME. We've got up here the Yorkshire Fatigue Clinic, who have been phenomenal in developing guidelines and resources to support our governing bodies and NHS trusts with resources to move forward with long COVID. But they're really busy doing that, so you've got me instead. But in all of my treatment with my clients, whether they've got multiple amputations or COPD, fatigue is such a strong part of their condition that I feel confident in talking about it and working with it. And it follows the normal principles. We're assessing, we're goal setting and planning. And sometimes those goals and steps are going to be smaller than they might be after another condition. We're trying to stabilise a condition, preventing this boom and bust cycle, looking to improve tolerance to activity and exercise, optimising employment success and planning for future progression, and setting expectations for relapses, because long COVID can relapse. In terms of symptom management, we're looking at the physical and emotional impact of symptoms. Cognitive behavioural therapy, graded exercise for mild to moderate symptoms, have the evidence base there. Activity management strategies, we're looking to sustain or gradually extend, if possible, their capacity for activity. We can use relaxation, sleep management, rest periods for energy conservation, pacing with graded exposure, looking at someone's diet, equipment that they might need, education and employment. And I think it's important to remember that no matter how much someone feels like they need to rest for long periods through the day, the evidence we have to date shows that extended periods of rest are not going to help manage this fatigue. So it is about assessed and supported capacity to cope with the increasing levels of activity that they need to do. But remembering that imposing a rigid schedule of activity and rest won't work. It's got to be a mindful process so the person learns to read and monitor what's going on with their own condition and how they can best manage it. And I want to say that you just need to remember, whether we're working in acute or community services, our patients present in different ways with different conditions, different comorbidities, and we rarely deal with just one thing at a time and ignore the rest of that person. We use our holistic approach. And this is no different. We assess what we find, we refer on or we treat, and we prepare them to self-manage ready for discharge. This is no different. We can do this. Now, I'm aware of the time. I know we started late, but I know a lot of you are going to be limited for time. You will get my slides on this, so I'm not going to go through vocational rehab in depth, but when we're looking at long COVID and the mean age, we're looking at working age adults. And work is a significant problem when they've got this brain fog and this fatigue and this breathlessness. And talking to employers who are already going through difficulties due to lockdowns and furloughing and all the rest, it's a really difficult time. So we need to work with our clients to have those conversations with employers and either support them directly or referring to other services. There are services out there through statutory services. There are other services out there privately. There's assistance with funding through Access to Work. There is lots of stuff out there, and I've put links at the end that will guide you to that support. So these are just what you're looking at on your COVID recovery website. The top one there is for guidance. It's easily accessible by anybody. And the bottom one is where you have to be referred into and supported with rehab from your team. Leeds Teaching Hospitals, and I'm sure many others across the country and the world, have published some great resources readily available online. These are just two for an example. Really helpful, not just for our patients, but for us as health and social care staff to read and absorb and share the information. It's critical now to share the information and develop these new services and ultimately that best practice. I do want to pay a nod really to people who not necessarily have got long COVID, but the people who are impacted by the treatment we're giving to those with long COVID and the situation in general. There's been a delay in treating people's long-term conditions and giving them the support they were used to. There's been occupational deprivation to us all through work, through lockdown. Cancer, heart disease, mental health and long COVID are on the rise and getting diagnosed later than they would normally because people have been avoiding going to appointments for fear of getting the virus or fear of adding to the strain on the NHS. People are experiencing bereavement and grief. They've lost their jobs, there's financial hardship and food poverty. Carer strain, young carers, old carers, caring for multiple people, it's been immense. And increased safeguarding concerns such as child abuse and domestic abuse with us all having been locked away. And I just ask you to keep those in mind when we're completing our work with people with long COVID. I don't need to talk through this one. This was just really for information, great infographic and a very accessible article that's worth a read. I've put all of my references on slides for you to click into. It is a bit of a rabbit hole. You go in, you click on one, and it just goes on and on and on. I could have talked for 4 weeks. Unlike me, to be fair. So the last thing is this slide. In Harrogate, we've got Hannah, the OT, who is working half-time for the COVID clinic. She's wanting to join or develop preferably a national, but certainly a regional service network. And rather than her getting lots of emails and dribs and drabs from you all, if any of you want to join a support network for information sharing and peer support, if you can email me, I'll take that as your consent and I will pull together a document and send it to Hannah and she'll be in touch with you all separately. So please do drop me an email if you want to join. And I'm so sorry that was a massive whiz through, but I hope it was useful.
That's been very useful. Thank you very much, Rachel. There's a lot to digest there and look forward to going through those slides in a bit more detail, as I guess others will as well. And there's quite a few questions come through, which is great. Keep them coming through. We'll cover those at the end of the session. Thanks again. So just moving on to Porrick now. Porrick Finn, our in-house physiotherapist and 6. Porrick's going to look at the specifying equipment really based on clients' long COVID symptoms in order to help management and really aid the rehabilitation process. So we'll just we've just swapped screens, so it should be back on Porrick if you're able to.
That's great, George. Thanks for that. So I'm just going to ask, first of all, can everyone see the slides? And can you, Rachel? Yep, that's great. So we can kick off basically. So my name's Porrick Finn, as George said. I'm a physiotherapist that works for Yorkshire Care Equipment. I've been with the company now about, I'd say, 8 years. And my main focus, my main job is out and about meeting OTs, physios, private clients, nurses, basically whoever needs some disability equipment, I will assess them. Now that equipment can vary from riser recliners and seating to bathing to ramping to beds, you name it. Basically, we do it. So we're going to have a bit of a focus more on a selective few of the pieces of equipment that we do today, rather than the whole broad bit, because we'd be here till 10 tonight. So we'll move on to the next slide, George. And first up there is the main symptoms that I'm kind of mainly going to deal with. Rachel's already touched on those, and that is breathlessness, fatigue, coughing, brain fog, joint pain, dizziness, feeling lightheaded. They're the kind of key ones that we're going to focus on. So if we just keep all those in mind, and then we'll relate them to the equipment. And then next slide there will show us some images of just some of the equipment that we'll be talking about today. So you've got the riser recliner chairs, although your picture there is a riser and recliner, but it's actually built into a sofa, which is a nice feature. So keep that in mind as well. We've got the Vela activity chairs, profiling beds, walking aids, and then some smaller household aids. So to kick off, we'll start with the riser recliners. And I'm mindful that we have a lot of people online. Everyone's from different backgrounds, and everyone has different levels of knowledge, etc. And we all come from different walks of life. So I'm going to try and keep the presentation so it's accessible to everyone, if that's okay. So I'll keep it fairly broad. Right, so the first one on the list there is mobile riser recliners. And that's not something people think of immediately when they think of a riser recliner. Generally, as you can see in the images down the right-hand side there, you have someone in their chair. It's generally allocated to a space within your living room, and you stay there. It's usually propped in front of the telly. But people tend to forget, well, ooh, could I get a mobile version of this? And the answer is yes, of course. So it would be very similar looking to what is in the pictures there. You would get also a handle on your chair, and you would have a larger caster. And then on that larger caster will come a brake as well. And the larger the caster, the brakes are really of a decent level, good high quality brakes on them when you have the larger caster. So obviously, if you have someone with COVID and they're breathless, then they might not be able to get around the house as well. So you now have the option of still having a lovely, comfortable riser recliner, but you could move them about the house or home. Another advantage to that is they can now go to maybe another part of the house where there's a better view. From a psychological point of view, that would be better, improve mood, etc. And it just mixes up the day for them. They're not stuck in the same corner, etc. So keep that in mind if you are yourself heavily involved in assessing equipment, or you have to go out and get equipment for people, such as the OTs amongst us, then keep the mobile riser recliner in mind. Moving on to back angle. Now that's a particular feature on a riser recliner, and it's basically the backrest can move forward and back. And you might think to yourself, well, that sounds like, you know, a very simple movement. What's the big deal about having a back angle on any chair for that fact? But in particular, the riser recliner. Well, if I hold up my hand here at the moment, hopefully you can all see us, is this here is the backrest. This is my seat. Obviously, you can then adjust that backrest to different angles. Now, having that feature on the chair will allow you to have the scope to maybe have better ventilation. So that will improve ventilation, because you might find that if you sit forward, your breathing becomes better. Some might find if I'm a little bit back, heading back in reclined in the chair, then your breathing might be optimized better at that angle. So just keep that in mind. You might think it's a very simple, basic movement, but it does help with people's ventilation. And anyone with COVID, any of these things will help. It also opens up the hips. So unfortunately, during lockdown, etc., a lot of people may have gained weight. And then with the opening up the hips, it allows us to spread a little bit more. So that may be an issue during lockdown where they have an increased abdominal area. Having the back angle means you're not so tight, an acute angle around the hip and abdomen area. So if you have your back angle, it means you can open up the hips, therefore giving you a little bit more space to breathe. Also to just keep in mind in terms of the ventilation, a key area on the chair is to think of the arm height. Arm height can help people who are maybe with their breathing. Some people find that if they elevate their shoulders, then that takes on the accessory muscles kick in, and that actually helps them with their breathing. Now, I'm not saying you have a fixed arm height that keeps you in shoulder elevation, because that's not good for you. That long term, you're going to get shoulder problems, but maybe we could consider an adjustable type of arm. So all these little extra features, etc., will help with the breathlessness in particular for the long COVID patient. Next on the list is knuckles. Now, knuckles are those at the front of your arm of your riser recliner. It's a projection of a piece of wood, to best describe it, which you can hold on to. And it looks quite nice on some chairs as a nice kind of feature in terms of furniture. It has that lovely wooden effect at the front. But for our primary focus for the knuckles is something that you can get hold of and grab at the front of your arms, the arms of the chair, helping with sit to stand. That would be the primary focus of it. Now, that will obviously help with rehabilitation, etc. So with the sit to stand as well as the stand to sit. Obviously, just keep in mind, you have to sit back down. Everyone kind of thinks of, well, I'm going to work on sit to stand, but it's just equally important to work on stand to sit. If you don't like the idea of knuckles, you can have the option of having the arms, which are on the chair, to come forward and be flush with the front of the chair. So most of the riser recliners are kind of recessed back a bit. They recede back a bit. So, and that's from a design point of view. But you can have those arms right up to the front, which also will help with sit to stand. Next on the list is pressure relief. Now there's various levels of pressure relief within the riser recliners, and it all depends on what your need is. Any of the long COVID patients, some of their symptoms may be so severe that they are sitting for long periods. They're very breathless, very fatigued, lots of joint pain. So therefore, having the correct pressure relief in case they are in case they're actually sitting for if they're sitting for very long periods, then we need to consider that pressure relief, because we don't want to develop sores, etc. Now there's different levels of pressure relief. You can have medium pressure relief, which is like a decent foam. You can have high pressure relief, which is also, you can have a very high level foam, or you can have gel. And then if you need even higher than that, it's an alternating air cushion with the pump that comes with it, very similar to the hospital beds. And then the second last point on there is the independent action. Now, what I mean by this is you can have riser recliners which have an independent backrest and have an independent leg. So you can action the leg up and down separately to the backrest. Now, when they work together, that's called tilt and space. But when you have them separate, then they're independent to each other. It's not a chair that we prescribe very often. It's a much rarer chair. But if you have someone with joint pain, and typically we have people with chronic back pain, etc., but those with the joint pain, is they need to dictate at what level their legs need to be, and maybe what level their back angle needs to be. And if you have the independent action, to be able to find that magic position. Whereas if they have the tilt in space, it'll keep them in that angle, and maybe their their pain will continue, and you don't want to encourage that. But like I say, it's a rarer chair. The tilt in space is more commonly used, but just keep it in mind, in particularly if they have a lot of joint pain. And then just to move quickly onto the drop arm. The drop arm is, if you think of severe cases, maybe of the COVID-19, they're really fatigued, they're struggling with the standing maybe, etc., then you might have to do a lateral transfer. So the arm drops down and you can move across from the side out of the chair onto another surface. You just have to remember it's probably best to have vertical rise, where that's the chair rises straight up rather than tilting you out. It goes straight up. That way you can be level with the next surface you're going onto. Okay, the next slide is the Vela chairs. Very impressed with this particular product. It's a very smart product. You might be looking at it looking at it initially there, you think, oh, it's just an office looking type chair. But it does so much, this particular chair. It's very adjustable. Now, it's on the first point there, it's electric height adjustment. Under those arms are two little buttons, and you can have them on either side, and you press those buttons and the chair rises up and down. And now that's very useful in terms of you're working at different heights. I've recently seen a lady who works in a factory, but our work surface is at different levels. So she'll be able to go up and down with just the press of a button, particularly if she has the joint pain, and she can rise up and down very easily with the, like I say, with the press of the button at different levels, at different work surfaces. Also keep in mind that this will help possibly with your sit to stand, because there's a very good brake lever on the chair. You can see it on the top picture there, it's sticking out at the side. It's nice and long, so it's easy to reach. You put on your brake lever, and with the different heights, you can practice maybe a stand at different levels to encourage quad strength at different angles. So on point 2 there, we've kind of touched on it as well, different work levels. So you particularly, if you're thinking of the domestic environment, the kitchen. So I'm seeing a lady at the moment in Sunderland who is working at different levels in the kitchen. She's doing lots of activities in the kitchen, and that chair allows her to go up and down easily to the different surfaces. Plus, she's able to move herself around on it. The beauty also of the chair is at point number 3 there is you have perch sitting. So the perch sitting allows you again to do more functional activities. It's achieved by the very easy height on the chair. It means you'll be able to do more in the kitchen, increase your mood, you start feeling better, etc. The mobility of the chair at point number 4 there is that you're able to wheel yourself about the kitchen, let's say. So you're starting to build up leg strength by propelling yourself with your feet around the kitchen or wherever you may be. Therefore, that increases your exercise tolerance, and it has, you know, good rehabilitation factors put in there to improve your strength, etc. overall. And just the last point there is superb office chair. And there'll be a lot of people out there with the COVID-19, with the long symptoms, who may have to return to work. And it is an excellent office chair, work chair for returning back to work. I'm currently seeing a lady who is affiliated to a museum, and she is working from home at the moment. She has some disabilities. Some of her symptoms are very similar to long COVID. And because the chair has so many levers, we can exactly set up the seat at different angles, the backrest at different angles, until she's literally 100% comfortable, because it's so flexible, the chair. So yeah, keep the Vela chair in mind, not just an office chair. The next one up is profiling beds, folks. Some pictures there again of some very nice looking ones as well. Some people might think in their head profiling bed, they might think of the hospital one, bit clinical looking, but we have a variety of beds now available, very, very good looking beds for the home environment, etc. That top picture demonstrates that. The number 1 point there is bed levers, and you must keep that in mind, because that will aid someone who's fatigued or breathless or joint pain, whatever their symptoms may be, to help them get in and out of bed. Vital tool. Some people forget about it. Sits at the edge of the bed. You get hold of it. It gives you that extra advantage of an anchor point to get in and out of bed. Also, just to keep in mind, we also supply turning beds, which is literally a bed that will rotate and take you in and out of bed. Very clever bed. So keep that in mind as well. But obviously there's the bed levers there, etc. Pressure relief is number 2 there. You may find yourself that you're going to have to be longer in bed. So it's very similar overlap to the pressure relief that I mentioned in riser recliners in terms of what different levels are. But just keep that point in mind, that if you're going to be staying for longer periods in bed because your symptoms are so severe, then when we come out and do the assessment with you, we can gladly speak through the pressure levels with you again and determine whether it's needed or not. Room for partner. A lot of people forget maybe the other person in the house who has no symptoms, but it's just important that they still want to sleep together. So you're going to look at a double bed, even larger than a double bed if you need to. We can do split bed. So maybe one side of the bed will have the profiling action. The other person mightn't need as much. So we just keep the partner in mind as well. So the functions of the bed, I'll just briefly touch on these because I'm mindful of the time, is you can have your head up. So the backrest comes up, you can sit up in bed. That's definitely going to help with breathlessness. Different angles, again, very similar to like the back angle on your chair. Which angle suits you best? Where are you getting most relief with your lung symptoms? The height adjustment on the bed, you could use, that's the whole bed goes up and down. Then you could use that to its maximum in terms of doing a sit to stand. So sit on the edge of the bed, use your up and down height adjustment, stand at different levels in different angles, just to increase your strength in your quads at different ranges. So you could use it as a rehab tool. And with the help of a bed lever beside you, you have something to hold on to as well. And then there's some extras in there, point number 5, such as monkey poles to help you with your bed mobility. There's a whole list of kind of bed linen available out there, different different products in relation to moving up and down the bed, slide sheets, etc. There's a whole list in terms of bed mobility, but that's something we could discuss with you on site. So that's profiling beds. Walking aids is you see the picture there again, very useful for anyone, again, with the breathlessness, having that seat. Why, if you have a little bit of extra cash, get the one with the seat, because you might be out and about, or you could be just in the house and you need to take a break and sit down, get your breath back. So definitely keep in mind the seat as very, very beneficial in terms of your breathlessness. Also, when the person is resting on the seat, use the high handles to your advantage by having your arms on the handles, which again will help with your breathing, because it'll elevate the shoulders. Ventilation will improve. Just little tips like that to help get the most out of your product. Having it foldable means you can put it in the car, and when when we're allowed to go out and about again, you may want to go out and then have it, having that day out will improve your mood. It's easy to store in the boot because it does fold really easily. Getting out will improve your exercise tolerance and, like I said, increase mood. So just having that feature on it allows you to bring it out for the day. A lot of these walkers have very good high level design in terms of ergonomics at point number 3 there. So if you have a lot of joint pain, the handles are very well designed to allow you to have good grip without causing too much pain. And we would look at that more closely depending on your symptoms. It's easy to break it as well if you haven't got much strength. The brakes are easily pushed down, etc. And then the final point there is storage. Now, the storage area on it, as you can see on the picture there, there's a wee bag. That means you know, you may be able to go out when you can to do some shopping. It takes your mind off trying to hold things, so you can focus on your mobility, you can put things away. It increases the functional activities. Long-term effects of being able to focus on your mobility, etc., will improve recovery. Again, lift mood, etc. So just something as simple as a storage bag. You might think, well, what's, you know, that's not a major thing, but it allows you to focus more on the job in hand. So just to keep it in mind as well. The final slide there is, or almost the final slide, is the smaller items. We have numerous amount of small items in our retail shop, which is over here in Harrogate, on the border between Harrogate and Nesborough. And you're more than welcome at any time to come into the shop and look at different items that helps with activities of daily living. There's just some mentioned there, the bath lifts, the grab rails, shower seats, something even as simple as things to help you open jars, etc. And that relates back to maybe because you're having joint pain. How can I make that easier? Literally could be here all day listing all the small items that we have in the shop. Some of them are extremely clever. So if you do get a chance, come in and have a look at those. On that slide there that you see is the resource center. Now that's very useful section of our website. And you can see written there, rise and recline chair justification template. On that section, we have a care chair, riser recliner, and other information on there that will help you justify the equipment that you need. A lot of the working physios, OTs out there, we all know, have to justify the equipment if they're getting it funded through a panel or some form of an authority. Then if you want help with that justification, we've done a lot of the hard work already, and that's all listed there for you. It's a very useful tool. Please make use of it. It will really help you with getting maybe that funding across the line. So please use that. And just finally to say, folks, sorry that I was a little bit rushed. I know, mindful of the time, etc. It was just a brief overview of some of the equipment that we offer, which was what we touched on: the riser recliner, the Vela chairs, the beds, and the walking aids. But we do so much equipment, with so many categories that we deal with in the terms of in the world of disability, I should say. So please feel free to book a joint assessment. We do so many with a lot of you will be online today with OTs and physios and nurses, and obviously private clients as well. And our number is on there. Just give us a ring and you can book a joint assessment with us. So thanks for bearing with us, folks, and hopefully you got something out of that.
Thank you very much, Porrick. That was useful, just to cover some of the equipment which is available for those who have got long COVID symptoms. So I think, if it's okay, conscious of the time, we'll jump straight into question and answer. Just a few questions which have come up. There's one we had here. I think I'll forward to you, if that's okay, Rachel. So, should a similar service to Harrogate's be provided in all areas? Is this a national structure, or is it down to individual trusts, CCGs, authorities, etc.? Don't know whether you could.
Yeah, the 10 million that was initially invested last year was to cover 69 local services across the country. So I have to reiterate, I'm not involved in one of these services, but from the research I've done, it is nationwide, and I've seen lists and lists. I don't know if they've got the full 69 up and running yet, but there are a lot. And I think as evidence comes out, more and more services will develop in what they do. But that's why I was talking about, we have to be mindful. It's all very well the guidance and the standards saying this is what you should be doing for best practice, but actually we're juggling that whole response service to the ongoing pre-COVID rehab needs plus post-COVID rehab needs. And we can't just magic this out of the air, however much money they throw at us. So I think, yes, it's national, but each local CCG and NHS trust are going to work slightly differently within the guidelines and the standards. But that's why these service networks, I'm hoping, will develop so that people can then share this information in local sort of more generalist rehab teams and carry across the effects of it all over.
That's very helpful. Thank you, Rachel. Well, we got you on. Another one here. So who gives the medical clearance as suggested on the slide reference return to work?
Right, okay. I mean, medical clearance will normally be, if we are looking at medical, not functional, it will normally be the GP. But if that person's been under the care of a consultant, whether it's been respiratory, psychology, general rehab medicine, or a specialist respiratory nurse, or whichever doctor has been taking care of them and their condition and the different bit of their condition, they'll be the person who says you can go back to work. And I think for vocational rehab, this is a whole other presentation, I think, for vocational rehab with long COVID, is that people can go back to work when they're not medically fit. They can have a sick note or a fit note and still go back to work if they feel well enough or they want to go back because of the financial implications of not being at work. And it's a really muddied area between employers, employees, medics and the therapists. And that's why I think the therapies involved in long COVID rehab need to develop a little bit of that competency-based learning. Even if you don't do vocational rehab, you need to have a bit of an understanding about people's rights at work, because we're going to be working with this age group more and more. And a big part of their problem is they're not getting back to work. And that has financial and mental health implications as well. So I think the GP or the consultant can give that medical fit to work, but as AHPs, we can fill in the fitness to practice documentation as well, using a more functional, wider focus rather than just the medical fitness to go to work, because you might be medically fine, but absolutely exhausted and not able to cope with a working day. So it's got to be a multi-pronged approach, really. So that's not really a direct answer, sorry.
No, that helps, because there's obviously a lot of, like you say, there's lots of approaches, different approaches that can be made.
Really useful though, and I think it's on my second reference slide. There is a link, som.com or som.co.uk, with a really accessible article with advice on what to do and what to share with your employer and what maybe not to share with your employer and what to ask for, and looking at reasonable adjustments. Because of course, when we look at the Equality Act, that applies to people with a long-term condition of 12 months or more. And even though long COVID may go on longer than 12 months, it hasn't at the stage they're diagnosed with it. So there's lots of implications for employers and rights there. So I think it's really important to look at these documents and understand what might apply to your clients, even if it's just to signpost them.
Good, that's very helpful. One for you here, Porrick. How much do the Vela chairs cost? Happy to chip in on that if you...
Yeah, you can as well, George. It will depend, and not to give you a short answer, it will depend on which model, because there's quite a variety of models available. And there's obviously very large ones, small ones. It depends what features you have on the model as well, whether you want the electric rise, do you want to keep it more manual based? What are you going to go for, super adjustable or basic? But I'll let you give a guide price on that, George.
Yeah, so you've got the manual adjustable. What Porrick touched on his slide was the electric height adjustable, which does more or less double the cost, as you'll appreciate, with a motor and the battery operation in there. In roundabout terms, you're talking for a manual operation chair around about the £1,000. Electric, you are talking at least double that, so about the 2,000 mark. I think it's important as well, as Porrick touched on, that this is very much a multi-use activity chair. So it's not just, although looking similar to an office chair, it's got some great functionality. So in terms of being able to use in a kitchen environment, a bathing environment, helping you to do those daily tasks that you may be struggling with when you're experiencing long COVID symptoms. Rachel, if you wanted to chip in on.
I was just going to say, I use them since I've discovered it. It's the Vela Tango 200, I think. I use quite frequently now with clients with amputation, really fantastic, with lower limb amputation, clients with fatigue. Obviously, there is an expense, but it's better than a perching stool. And obviously, if someone just needs a perching stool, that's fine. It would be completely disproportionate expense. But actually, if someone's fatigued and they are safe on assessment to wheel themselves around with 1 foot or both feet, it's quick, it turns on a sixpence, it's great in the kitchen, it's great in the office, it's great in the bathroom. And obviously there's issues on multi-level floors and what have you, but subject to assessment, it can meet a massive amount of needs and actually becomes great value for money when you're looking at cost per use and the type of things it can be used for. I absolutely love it, and I am an absolute advocate for it. I think I discovered it a few years ago and I use it a lot now.
That's great, thank you. So we'll, conscious of the time, we'll round off with just one more question and direct this to you again, Rachel, if that's okay. So is there any guidance or additional provision for those who as a result of COVID have long-term impairment but not necessarily long COVID, e.g. amputees as a result of COVID-related sepsis? So I suppose it's kind of knock-on.
Yeah, I mean, I don't know is the answer. I don't know what is out there for those people other than the standard services. So this is where I talk about the specialist services. If we've got someone who has had an amputation because of sepsis from long COVID, they will be in with the amputation services. And if they are experiencing other long-term conditions, symptoms of long COVID, then that's 2 separate things, but where we need to be competency based in our treatment so that we understand those symptoms. Because someone, say for example, with a lower limb amputation, their level of fatigue at effort of mobility is much higher than someone with both legs. So add in long COVID fatigue, you know, it just builds and builds. But if they don't have any long COVID symptoms and it's as a result of COVID, I think then you're just going to be in your standard care pathways for that condition. But I guess that's where that collaboration and communication between services lies. But if there's any additional funding or servicing, I'm afraid I just don't know.
No, that's great. Well, thank you. Sorry, another question has just popped up. Apologies for those that I haven't answered the questions to. We will definitely do so in the next day or so. Question here, do you do joint assessments all around the country? Well, really the whole COVID has turned a lot of things on its head, as you can appreciate. So at some stages we were unable to carry out as many of the home visit assessments as we normally do. And we found by embracing technology, using video, it's amazing what you can achieve and overcome. I don't think anything quite beats a physical on-site assessment, but there are ways around working. So in answer to your question, yes, we do cover assessments all around the country, and we can, you know, very easily carry that out by video and also on site as well. So thank you very much for all. Apologies again for going over time. This is, I'm sure, going to be the first of many webinars that we'll run. Thank you very much, Rachel, for your contribution. It's greatly appreciated, and Porrick too on the equipment. And we will be sending out a feedback form, which we'd really appreciate. Positive, negative, that's no problem at all, so we can improve on these sessions. So with that, we'll close and have a great rest of the day all. Thank you.
Thank you.